set aside
more that our health
technology
system
is
focuses
siloed
on the
to have
social
We talked about the
determinants
state of
of
healthcare.
the better off.
Access to care seems to be a genuine across-the-board concern. Dr. Freeman, let's start with you. Can you talk to me a little bit about what access to care means to you and your patients? And what I'm really interested in is your thoughts about how we can improve access to care. Is it simply a matter of money? Can we streamline the system? What can we do to improve access to care? What can physicians do?
Well, I'm a mental health professional, so I'm going to talk about that particular point. Number one, being able to have insurance, what we call a self-pay or cash business or concierge service. You have the luxury of having access without the need for insurance. However, if you do have insurance, you have to, number one, have someone who's willing to accept it. And then if they are willing to accept it, at least within the mental health realm, there is a significant delay in terms of being able to get an appointment. And then if you are able to get an appointment, then to be seen by someone, and then what Dr. Azus referred to in terms of formularies or certain medications, even though the clinician may prescribe a particular medication that they know is going to work, and that's usually why they choose it, they may then later find out that the patient's insurance will not cover it. And so there's a delay, there's a lot that goes on between, and it just doesn't hold true for mental health services, it holds true for many services. So the point at which I make a clinical decision regarding a particular medication and that patient actually receiving the medication, there are a lot of things that can occur to obstruct that. And so in terms of what we can do, well, when I think of our training, and we were all trained to provide the best quality care, that's usually the first thing that comes into our mind when we're having an exchange with a patient. And so if you are asking me, when I'm trying to provide the top quality care, am I thinking, is there a cheaper generic? Is the insurance company not going to pay for it? All of these things. That's not what I'm thinking about. And Dr. Krause talked about the need for engagement. And it's when you're on the ground trying to provide top quality care and you're bombarded with all of these obstacles, which could be in the form of, well, you need not only a prior authorization for treatment, meaning you need permission to provide the services you're skilled to provide, you also need permission to provide the medicine that you feel is in the best interest of the patient. And so oftentimes you don't even find out that these barriers are in place until after the patient is gone. And then, you're talking about access, so even if the patient can get to you, you can actually provide the care that you're trained to give. Then there are all of these other things, barriers, that prevent the delivery of top quality care. And so having insurance is not necessarily the answer. So there are many other things to consider, but I do want to echo, as someone who is not only trained to care for people who live in the margins, because according to society, I am defined as someone who lives in the margin. Yet I have the ability to provide care for everyone. By living in the margin, I have an emotional connection to those who may not have direct access to the best care. And so emotionally, I'm more committed, or I am committed, because I really can't measure, more or less. But the challenge is that irrespective of my, intellect and training and experience, if I'm in the trenches and my patients are not getting the kind of care that I believe they deserve, then I can either complain about it, I can stand on the sidelines, or I can get in the game. And the thing that I value most about LACMA, about CMA, is the ability to have a voice, a collective voice, and to be heard. And through my experience, through LACMA and CMA, I've been a witness to the ability of physicians to really impact the legislature in a way that protects our patients and gives them access to the quality of care that they deserve.
Thank you. Dr. Kurian, what are your thoughts about access to care?
So in public health, we sort of live in this ideal world where we're not as concerned in our clinics about insurance or whether people have an ability to pay. We just provide services regardless of that situation. So it sort of represents the ideal. But I think in terms of access to care, there are other considerations because care can be not just the clinical provision that you're providing a patient, but other upstream issues like the quality of their housing, which can impact their health and well-being, their ability to get to appointments, the quality of the food that they're eating, all which impacts their health. So I think this is sort of an interesting and there's an opportunity here for the Department of Public Health to collaborate with LACMA and provider groups to really address issues that impact quality of care from a different perspective. So not just actual clinical provision, but how can we work together to try and address some of these other issues that have equal impact, perhaps, on a patient's health and well-being.
And I suspect the matter of physician engagement is a critical factor in finding solutions to the access to care.
Oh, absolutely, especially when you're talking about these sort of issues around access and access to these social determinants. Coming together as a group, working with organizations like LACMA, it's much easier than an individual physician trying to work with the Department of Public Health to try and get, for example, a community worker program set up so that somebody can come out, or a public health nurse to come out and work with that one individual. But if you have a collective voice that tries to establish programs with provider groups, I think you have much better opportunity for success.
Dr. Russo, access to care.
Access. Well, I'm going to take a little bit different tack on this because there's what we've been discussing here is really on the front end at the receptionist desk. Do you have an insurance card, and what's your deductible or what's your copay? And I think we've talked about that a fair amount. But on the other end of that provision is do you have doctors? Or do you have other providers? And that, I think, concerns all of us. We've talked a lot about this, but while we have 2 new medical schools, well, at least 1 new medical school in Riverside, and the Kaiser folks about to build another one in Pasadena, that will certainly help with having more access to train new physicians. But what I understand from my reading is we don't have a lot of residency programs, enough residency programs to turn out enough primary care doctors. And the residency programs that we do have are oftentimes today turning out people who could go into primary care. They're opting to go to hospitalist medicine, or they're opting to go to subspecialty work. And certainly I don't want to deny anyone to seek what's in their heart and soul in terms of how they provide service to the patients, because those are all needed to some extent or another. But we do have a significant dearth of adult primary care. And that's an issue that I don't see being solved very well. There are opportunities for physicians to take advantage of loan repayment programs, and those have been around for a while. I'm not sure there's enough of them, and frankly, I'm not sure that a lot of people have the fire in their gut to be a primary care physician. It ain't easy. I've been one, and I struggle from time to time having to encourage doctors to stay in the clinic and not go elsewhere. We're all competing for the small number that are out there, and it's getting more fierce. So the market is clearly being driven to try to encourage those people to go into primary care as opposed to specialization. So that's an issue that I think is going to have to be dealt with. Now, nurse practitioners and physician assistants are a potential solution to that, but I think we're still going to be left with not enough MDs and DOs that are willing to do that a lot of work. And that's not to dismiss, obviously, the importance of specialists. I talked about that earlier in the program, the need for that, particularly in the indigent population. But I think a solid primary care doctor who's willing to take ownership of the patient's medical problems can handle a lot of medical stuff and make the referrals that come to my colleagues who are on ophthalmology here and psychiatry a much more worthwhile event. What I have seen over the years is that some primary care physicians, they get good training in terms of how to take care of a septic patient or a patient with ischemic cardiomyopathy in the ICU, but they can't tell seborrheic keratosis from a basal cell cancer, and so they end up flooding the dermatologist with things that probably could be taken care of in the primary care world. Dermatology is one of the least available specialties, as far as I can tell, except for the rich, and so having people who are willing to take ownership of that at the primary care level of things that they should be trained to do and at least should be able to get a comfort level with is important. I mean, how much red eye can you tolerate seeing in your office that doesn't need to be there? I don't know how much that happens, but there's a need for more primary care physicians and for those people to be better trained to deal, or well trained, I don't want to say better trained, but well trained to deal with things that can be done on the front line. It saves patients additional copays, which is an expense to the system. It also saves them from having to take another half day off from work to go see a specialist that perhaps is not always needed, so that the specialists can be available when you really do need them. Because the last thing you want is, they're buried in stuff they don't need to be seeing, and you can't get your patients in who's got a significant medical problem that you can't really deal with. So I'm sorry I've gone a bit long-winded, but it is important to recognize that there needs to be something done about that issue as well.
So relative to that, there's a shortage of funding for graduate medical education in this country. So as we're expanding medical schools, we are not kept up with graduate medical education funding, which is a huge problem for the medical students we're graduating who may have significant educational debt and then cannot find a residency so that they can become fully licensed. With regard to that, in California, there's a proposal that's going to be coming out through the medical board to move licensure of California physicians from after the first year of postgraduate education to after 3 years of postgraduate education before receiving a full medical license, which will aggravate the problem even further.
What's the rationale for that?
You'd have to ask the California Medical Board. Right. So I don't really know the rationale, and that's one of the things that the Medical Association will be taking up in the coming year if that proposal comes forward.
I know you looked at Dr. Krause, who serves on the medical board.
But he's not here speaking on behalf of the medical board.
No, I understand that, and he made that clear. But, Dr. Shiba, I don't want to pass over you and give you a chance to talk about access to care.
Sure. One thing I think that would help is, all the technology and innovation in medicine right now. I think that's one area that's often overlooked. Say, for instance, telehealth, where you have patients who are in very rural areas who might not have access to a dermatologist, And if you could have the ability to see a high resolution digital picture that's sent to a dermatologist in maybe a more metropolitan area, that could do a lot for that patient. So I think that any promotion that we can do in regards to telehealth would be helpful in terms of access. Any kind of technology or innovation, rather than just looking at location and distance, I think if we were to look at metrics that would help, in terms of developing that would be helpful. I think I just wanted to make a comment too about LACMA in general. Is I think the value of this organization is just the collaboration that I've seen just among us leaders. I currently serve on the executive committee of LACMA and also am a CMA board trustee. But I think regardless if you're a solo private practice physician, you're in a small group, or you're in a large group, your mode of practice, or what system you work in. Are you in academics? Are you hospital-based? Are you government-based? I think what's beautiful about LACMA is that you have this great collaboration of physicians from different specialty backgrounds, modes of practice, who all work together on behalf of physicians in Los Angeles. I don't think any other medical organization anywhere in California is going to know LA physicians better than LACMA.